Hi, I'm Scott Novokuski, Director of the Mount Sinai Interventional Fibroid Center.
Hi, my name is Dr. Vivian Bechet. I'm one of the interventional radiologists who practices at Mount Sinai and at the Fibroid Center.
Hi, my name is Allison Gordon. I'm one of the nurse practitioners in the interventional radiology department, and I specialize in the uterine fibroid embolization procedure.
I'm here today with my colleague to discuss uterine fibroids, what they are, their symptoms, and treatment options. I'm also going to touch upon what our institute is doing to keep you safe as we are emerging from the COVID pandemic. Finally, we'll answer some commonly asked questions about fibroids and their treatment. Vivian?
All right, thanks, Scott. I'm going to talk about uterine fibroids, what they are, and how we treat them, and then we'll come back together and answer some questions and answers about fibroids and the treatment we offer. So to start, what are uterine fibroids? So they're benign tumors. They're very common. They arise in the uterus, and they really don't pose an issue unless they cause symptoms. There's a lot of variety of symptoms that can go along with fibroids, depending on where they're located within the uterus. So on this slide, we see different locations. Some of them can kind of hang within the uterine cavity. Sometimes they can be exophytic, which means they hang on the outside of the uterus. And other times they line the mucosa or the lining of the uterus. And depending on where they are and the number, they can have different impacts on a woman in terms of symptoms. So women can often have heavy bleeding if they line the mucosa, the inner lining. They can have bulk symptoms related to the fibroids as well. And so, you know, these can really impact significantly on a woman's life. Like I said, they're very, very common. So it's estimated that almost 50% of women will actually develop fibroids at some point in their lifetime. But typically they're diagnosed within the 30s or 40s, sometimes when a woman is trying to get pregnant, sometimes just when they're menstruating, because they can often cause heavy menstruation. And so if you're having symptoms, that may prompt someone to see their gynecologist and then have a diagnosis made of fibroids. Only about 10 to 30% of women have symptoms associated with their fibroids, and that's when these tumors, which again are benign, meaning they're typically not cancerous, can pose a problem to a woman. Symptoms occur in fibroids. Again, typically the main ones are heavy bleeding, sometimes what we call bulk symptoms, which are things related to mass effect. So if you have a lot of fibroids, because you know they don't necessarily occur singular, sometimes there can be multiple or almost innumerable fibroids filling the uterus. That can cause the uterus to be quite enlarged. And so women can have urinary symptoms from that. Women can have constipation symptoms or heavy cramping during their menstruation, spotting in between, things like that. How do we diagnose them? So again, usually they present to a person when there's symptoms related to them, and then that prompts a gynecologist to do further evaluation. She'll do a pelvic exam, or he will do a pelvic exam. And then it may require further imaging. So typically an ultrasound is the first one, a pelvic ultrasound, and that can be fairly diagnostic to tell you whether you have or you don't have fibroids. To get better characterization of how many you have, where they are, an MRI is sometimes warranted. So often we'll recommend that women will get an MRI before any form of treatment. So that leads me into the treatments of fibroids. And if you're not having symptoms, really treatment may not be needed. Just because you have them, again, because they're benign, if they pose no impact on your lifestyle or you're having no side effects, you may not need to have them treated at all. But if you are having symptoms, then typically the initial treatment that will be initiated is some form of drug therapy. So a birth control pill, a hormonal therapy, an IUD, something like that, and then symptomatic control with either non-steroidal anti-inflammatory, such as ibuprofen, can help. If a woman has really symptomatic fibroids, she has anemia because she has such heavy menstruation, that these kind of therapies may be beneficial, but they may not have, complete impact on the fibroids to an extent that it actually alleviates those symptoms. And so there is a spectrum of sort of treatments that you can be offered, that you may be offered by your gynecologist, or if you meet with an interventional radiologist. Some of them are listed here. So myomectomy, where the individual fibroids are actually scooped out of the uterus, and I'll go into the ways in which that's undertaken. Sometimes it can be laparoscopic, sometimes depending on the size and the degree to which you have fibroids, you may have to do an open surgery for that. Sometimes it can be through the vagina. Hysterectomy it may be recommended if you have so many fibroids and you're at an age where, you know, maybe the patient's preference is that they don't want to have the uterus, and that's the patient's prerogative, but that's just one option. Obviously, that's a bit more of an invasive surgery. Ablation of the endometrium, where a probe is placed inside the uterine cavity via the vagina and is actually burning the lining of the endometrium. There's a therapy that is a little bit limited in its application, but it can be beneficial depending on the location of the fibroid, which is called HIFU. And then you have fibroid embolization, so uterine artery, or sometimes called uterine fibroid embolization, or sometimes we call that UFI, is a therapy that is very minimally invasive and can have an impact on all fibroids. So it doesn't necessarily target one fibroid, it'll treat all of them in one sitting. So here I'm going to show an image of a laparoscopic approach for myomectomy. So multiple laparoscopes are placed, and this can be helpful if, you know, there's one to several fibroids that need to be removed. Again, this therapy can also be sometimes transvaginal, depending on where the fibroid or the fibroids are. But you can imagine if you have a lot of fibroids or your uterus is very large, that you may need to actually have an open surgery. And we'll show a couple images of that where the uterus is opened up and those are kind of excavated out of the uterus from an open approach. And so depending on what type of approach will dictate what sort of recovery. But, you know, hysterectomy, it's surgical removal of the uterus and the fibroid. Sometimes the ovaries are removed. You're doing an abdominal incision. Sometimes it can be vaginally, sometimes laparoscopically. And so that would be the most invasive, technically, you know, looking at the degree of the surgery. Advantages, it's 100% curative. You're taking out the uterus, you're taking out all the fibroids. Those fibroids are never going to come back. There's no risk of, you know, recurrent fibroids because you don't have the milieu there anymore. You don't have your uterus anymore, and it's a well-established procedure. Drawbacks are that it is a larger surgery, and so recovery time is going to be larger, and the risks kind of go up. Even while it's a well-established procedure, there are always risks associated with everything. And so there are risks that are associated with that. So disadvantages, again, it's a major surgery. There can be surgical complications, infection, hemorrhage, adjacent organs can be injured, there can be adhesions. Obviously, there's no potential for childbearing after hysterectomy. Recovery time can be up to 6 weeks. And if your ovaries are removed in the setting of the hysterectomy, you can have hormonal changes. As far as fibroid embolization, which is what we perform, and we're going to focus a little bit more on in these last few slides that I'm going to touch on, is it's a well-studied procedure. It's been done since the 1970s, so we have a lot of data on it showing its safety. Initially, it grew out of actually treatment for bleeding, pelvic bleeding. So say postpartum, a young woman is bleeding actively and it can't be controlled. It's a very similar procedure that's undertaken to treat that bleeding versus the application of treating fibroids. And so we have a lot of data to support its safety from as far back as 1970, and then it's since been honed to be used for treating more selectively for fibroids. It's minimally invasive. It's basically performed through a pinpoint hole, either through a blood vessel in the groin or through the wrist artery. So you're leaving with a tiny bandage. There's no sutures. This is performed by specialized physicians who have almost a decade of training to do what they're doing, and we're called interventional radiologists. So you meet one in consultation before your appointment to review the pros and cons and all the other options, since we're kind of well versed in all of them. And so you'll meet with one of the interventional radiologists who specialize in fibroid treatment at our fibroid center and go over all these options and the benefits and drawbacks of each of them. How is the procedure performed? Again, so you're going to go through a pinhole in the wrist artery or the groin artery, and a small catheter is going to be thread from that artery, almost like roadways, out to the artery that supplies the fibroids. And there's two of them. There's two uterine arteries, and they tend to supply the fibroids. So we selectively go out to them. It's not a painful procedure, but you are given moderate sedation during the procedure. It's all done in a sterile operating room type of room with our ability to look inside your body through X-ray. And so that's how we're able to do a procedure without having to create large incisions. It takes about an hour to perform. And we're basically cutting off the blood supply to those fibroids. That kind of starves them. And then they will slowly shrink over time. And as they shrink, the symptoms associated with them will go away. When you're done, again, like I said, you have a small Band-Aid either at the groin or the wrist. And that's all you're going home with. It's a same-day procedure. So you're not staying overnight typically. We've been doing this quite a long time, and we've performed this on thousands of women, and we have a large-scale study looking at our ability to safely discharge women on the same day. There's tends to be a large preference for that, to be at home after the procedure, and so by and large, over 95% of women are going home the same day, with well prepared to deal with the post-procedure symptoms, which we'll talk about, and exactly how patients are set up to feel really comfortable before, during, and after the procedure. Like I said, it's typically done with conscious sedation, about an hour, and again, usually a same-day procedure with patients going home after the procedure. Post-procedure, it's fairly effective. So we have studies that show somewhat of a range, but between 78 and 94% of women who have the procedure will note complete or significant relief, particularly when it's related to heavy menstruation. That tends to be this tends to be a really effective treatment. And again, it's treating all the fibroids, not targeting specific ones. So it's a nice kind of global therapy. Recurrence of fibroids, of the treated fibroids, is very, very rare. So that's really atypical. And so it tends to be a really, for the level of invasiveness, which is low, it tends to be a really well-tolerated therapy. So again, the advantages are that you're treating all the fibroids simultaneously, minimally invasive, recurrence is rare, you have a much shorter recovery time, and we'll go into that in a little bit more detail. It tends to be, you'll have pretty bad cramping, abdominal pain. We usually say kind of imagine your worst period kind of cramping, typically 48 to 72 hours. And then thereafter, it drops off significantly. And we have medication that we prescribe, and we explain exactly how to take it to kind of tap down that inflammation and pain that you have from the therapy. Minimal bleeding loss, that's really not a major risk factor. There's no need for transfusion during the procedure or anything like that. As far as disadvantages, there's a small percentage of women who don't have a full response to this therapy and may have to go on to something more invasive like a hysterectomy or even a myomectomy. The chance of serious complication is very low. It's between 1% and 2%. And then there's a risk, particularly in women who are approaching the age of menopause, where you can have early onset menopause or early ovarian failure. We typically see that in women over 45. So at this point, I'm going to turn it over to Scott Nowakowski, who's going to go into a little bit the before, during, and after of the procedure, sort of the logistics of it.
So how are we keeping you safe? Our staff will call you prior to your visit to ask if you have COVID-19 symptoms. To reduce your wait time and contact with others, as much of your check-in as possible will be handled electronically before you come in. When you arrive, all patients will be screened for COVID-19 symptoms, including temperature checks. Patients showing symptoms will be referred for appropriate care. Throughout your visit at Mount Sinai, all patients and staff are required to wear mask face coverings, as well as appropriate protective equipment. Patients and visitors will be provided with a mask if needed.
We are now welcoming visitors into our hospitals with guidance from New York State. Please visit our website at mountsinai.org for the most up-to-date information.
During your visit, there's no better time to emphasize the importance of hand hygiene. We recommend that you wash your hands with soap and water for at least 20 seconds frequently. We also will make alcohol-based hand sanitizers readily available for our patients and staff throughout our health system in case you don't have access to soap and water.
We're minimizing contact between patients and spacing furniture, minimizing the number of patients in waiting areas, and scheduling more time between appointments. We are monitoring the number of patients in elevators. You will also see visual aids of our elevator safety guidelines. We also encourage the guidelines for social distancing, which is to keep 6 feet separation.
Behind the scenes, all areas are rigorously disinfected, including waiting rooms, patient rooms, operating rooms, and high-touch surfaces. Patient rooms receive ceiling-to-floor cleaning after a patient has been discharged and before a new patient is admitted. In our outpatient practices, examination and treatment rooms are disinfected between patient visits, and high-touch surfaces such as doorknobs and kiosks are continually cleaned. Our staff are monitoring themselves for signs and symptoms of COVID-19 twice daily and being tested for exposure to COVID-19. Now we're going to answer some commonly asked questions. First question, when would you be able to return back to work post-procedure?
Typically, patients return back to work within a week, some variation. You can expect 48 to 72 hours of recovery with cramping pain, then big improvement, and a return back to normal activity.
What should you expect your menstrual cycles to be like post-procedure?
We typically tell patients that you're going to expect your menstrual cycle to kind of go to its new normal within 3 cycles. So it's not an on-off switch when you have the procedure. The fibroids need a little bit of time to shrink down, and that's how your symptoms will behave as well. So sometimes you can have still some spotting in between periods. You may have passage of some clots, but typically by the time that you come back in to see us in consultation, after that in clinic, 3 months afterwards is when you're going to kind of have your new cycle and be feeling the change really in your symptoms.
How long will it take to see the success of the procedure?
Like Dr. Boucher had said, patients usually see lighter cycles and a significant symptom improvement by 3 months, sometimes sooner. The fibroids continue to shrink, and we see you back in the office in 6 months with an MRI to evaluate all the fibroids.
Will your insurance pay for uterine artery embolization?
Most insurance plans will cover uterine fibroid embolization. We have a dedicated team to ensure that you have coverage before the procedure and to help with any questions about coverage.
Will someone walk me through my post-procedure care?
Absolutely. There are going to be a number of people on the team who are dedicated to making sure that the process is clear and streamlined for you when you come in. So that starts, from the first time that you come to consultation, and we review sort of the medication and the plan for post-operative care. Once you've decided that you want to go ahead with uterine fibroid embolization, you'll be talking to Allison, actually, who will make sure that all your medications are pre-filled, that they've gone to your pharmacy, and that you've picked them up before you even come to the day of procedure. You'll also be hearing from one of our nurses the night before to make sure that you know exactly where to come, at what time, and exactly how to prepare for the procedure day. And then the day of procedure, I'll obviously be meeting with your doctor again before we go in to do the procedure to answer any questions that you have or address any thoughts that you have before we start the procedure. You'll be meeting one of the other nurse practitioners on the team as well, who's going to walk you through the medical packet that we send you home with, which has contact information so that you can reach someone 24 hours a day. It also has a very clear layout of exactly how you take your medications post-procedure. And she'll walk you through all those and make sure that that's clear exactly how you take the medications. And so you'll be in contact with all those people throughout the process of pre-procedure, during the procedure, and post, and again, access to all of us and the team 24 hours a day, really, after the procedure as well. Another question people have often is exactly what the day of the procedure is going to be like.
You will typically be first case in the morning following 8 hours of fasting. You will meet our team, receive an IV, and pre-procedure medications. The procedure is then performed in our angiography suite. Following the procedure, you will stay in our recovery area for a couple of hours before you can go home with a friend or family member. Your medications and discharge packet will be reviewed with you prior to leaving the hospital.
What can you expect after the procedure?
We typically tell patients to expect kind of the worst cramping period that they have. So we like to prepare patients to kind of expect cramping and not feeling so well for typically 48 to 72 hours. We really set you up at home in terms of having all the medications you need to treat those symptoms. I like to tell patients to kind of, if they can, have a buddy with them who can be around for those first 2 days or so to help them get them what they need. And then often the things that help you when you're having a bad period are things that are also going to help during the post-procedure. So some women like to keep a heating pad on their belly. Those things can help a lot too. And it's also very important to follow the medication regimen as it's prescribed. Some of the medications are sort of around the clock, so not necessarily just because you're having pain. You'll take that preemptively to kind of prevent more pain from developing. So, together with all those things combined, women do pretty well at home, and the vast majority of women do go home the same day and prefer to be at home. I'd say over 95% typically will go home and prefer to be at home. In rare cases, if someone's really not feeling well post-procedure to a degree where we don't want you going home, we always allow for the opportunity for patients to stay. But again, by and large, most women that we've surveyed tend to prefer to be home and in the comforts of their own bed post-procedure. After that, after the first 2 to 3 days, typically the symptoms subside significantly, and usually by a week, you're feeling basically back to normal. A lot of women ask whether their fertility will be impacted from this procedure.
Not typically. However, there's a small percentage in the literature whose fertility is affected, and that rate goes up as you're closer to menopause. If you are actively seeking to have a child and are a candidate for myomectomy, we may recommend that you see a gynecologist. We can assess all of these factors when we meet you in consultation.
If you would like to schedule an appointment, please call the number attached to the post, 212-241-4046. Thank you very much for your time.